My day starts early, and by early I mean around 5 o'clock in the morning. I wake up and the first thing I do is make my coffee and meditate for 5 to 15 minutes. After that, I get ready and go to the gym. Going to the gym has been the most crucial thing for me in my training. I've been doing my residency for the last 4 years and I have another 4 years of training. What helped me to go through my medical training has been the gym. It's the place where I relax, it's the place where the most creative ideas comes to me. And then I start my day. Good morning. So, welcome everyone. My name is Roupen. I'm currently training to become an oncologist. So this is a short video. How is it like to be an oncologist? What usually goes on the day of an oncologist? So people better understand the Oncology Fellowship and the oncologist lifestyle in general. Okay, so I usually start my day in the morning like around 5. I wake up at 5. The first thing I always do is I hit the gym early in the morning. That's very important for me. And I usually try to exercise for an hour or hour and 10 minutes. But tonight I'm on call, so I'll be at the hospital working overnight as well after I finish my day in the clinic. So this is gonna be a busy day. But even though I'm on call, I always try to go to the hospital in the morning. I always try to go to the gym in the morning and exercise and work out, even for a short period of time, and then go to the hospitals, to the clinic, see my patients, and then go to the hospital to be on call on the ward overnight. All right, so let's start. I just finished my workout routine in the morning. I'm gonna go shower, change, and then head to the clinic. Usually the clinic starts around 8:30. I try to arrive a bit earlier. And right now I'm training to become an oncologist, which means I specialize in the treatment of cancer. It's a very challenging and rewarding field. And every day I'm very grateful to be able to help my patients through their difficult journey. In the clinic, we see patients with a variety of different cancers, ranging from very common to very rare. When the patients come to the clinic, the first thing I do is try to listen to them. I want to hear their story, understand their concerns, understand their goals, and know them as a person. From there, with them, with my staff, we work together to develop a treatment plan that's tailored to their individual need. Every cancer is different. Cancer is an orphan disease. There are different treatment options for cancer, like surgery, radiation therapy, chemotherapy, immunotherapy, or combination of these approaches. There is some art to it as well. My job is not only to provide patients with the best possible care, but also support them emotionally and mentally. So finished the clinic for today. It was a very interesting day. So on a clinic day, I usually see so for today it was like mainly gastrointestinal cancer. So I saw a patient with esophageal cancer, I saw a patient with stomach cancer, I saw a patient with colon cancer. So those are the bread and butter cases when it comes to the cancer presentation, the gastroenterology clinic. Of course, there are more rare cases we see as well, but this is how usually clinic goes. It's the interesting thing about oncology and why I really like oncology. You see patients from different ages. Cancer doesn't know an age, right? Today I saw a patient who's 31-year-old and I saw a patient who's 85-year-old. It's not always about the age when it comes to cancer treatment. Many people think that there is lots of misconception that if you are old you can't get treated. Actually, that's not the case. Even if you are old, you can get treated if you are doing well, if you are performing well in life, if you are independent, you are able to take care of yourself, if you are able to walk without a walker, drive, dress, eat, feed yourself. If you are functionally independent, even if you are old, you can still be treated. And one of the other misconceptions about oncology, the field itself, something I heard a lot about residency, that it is sad. This is not the case. I would say, like from my experience as a resident, I've been a resident for 4 years, and I would say the saddest rotations I ever had, it's been mainly like critical care, ICU. Many people, because like those patients have the most aggressive type of diseases, and you have end of life discussion with 2 or 3 patients a day. But in the cancer clinic, I might have an end of life discussion maybe twice a month. It also depends on the type of cancer and what kind of cancer you are treating. Usually in prostate cancer, this is not very common. In pancreatic cancer, it's common. Pancreatic cancer is more aggressive. So cancer is not a sad specialty. It's not like you're going to have palliative discussion with everyone, with all your patients. This is a fairly common misconception that residents and medical students have about oncology, and it's very amazing field, especially now with the rise of new medications, immunotherapy, crazy amount of clinical trials that are going on right now. So now I'm in the hospital, so we have our own core rooms, and I already put my stuff in the core room. So we stay in the hospital overnight to admit patients and see new consults. I already took the handover, which is now I'm just gonna sit down and wait for consult. I already was paged by the emergency for a patient who has a breast cancer. So this patient is on chemotherapy. So she's on a regime we call cyclophosphamide and docetaxel. So this also when we put patients on this type of chemotherapy, one of the side effects is it really affects their bone marrow, so their white blood cell count might decrease, and we might give them medication called Lapelga, which help to increase their white blood cell count, to maintain that white blood cell count, right? So this patient presented with a rash on her scalp and her back, and one of the emergency physicians called me for an opinion, asking if this is related to the chemotherapy or is it related to the Lapelga. So I wasn't really sure. It's a very tricky situation. So I called the staff who's on call with me, and we discussed her case, and based on the findings, we don't think it's related to either. And the patient was stable, so we said she can go home. So during residency and during fellowship, when you're on call, there's always a staff with you on call, and there is something, if there is a question or a patient don't know how to manage, you can give the staff call and you can always discuss the patient's case with them. And I always felt supported during residency and hopefully also during fellowship. So yeah, that's the first patient for tonight. If there are any consults, I'll keep you updated, and let's see how it goes. So I was patient to see another patient in the emergency, and I usually when I'm on call, I really like to use the stairs. I like to keep active, although I exercise today, but hey, some activity is good, and it's still early during the night, so I do have energy. So let's go. I saw already 2 patients. I admitted him to the ward. And after that, it's around 9:15 p.m. I want to get some sleep if I can. So I'm going to change, I get my scrubs. I try to avoid drinking coffee after 4 p.m. In case there are no consults or no admissions, I can get into sleep. But that being said, there are nights where it's really busy and I don't get any sleep overnight. So I was page again, so I'm gonna answer this page. I was trying to take a nap, and usually this is a bit hard when you're on call, but I just try to close my eyes and take a nap here and there. So I'm just gonna answer this page and I'll let you know what's going on. Being on call overnight can be sometimes stressful, but after 4 years of internal medicine residency and around 200 overnight calls, I learned that the trick to do well during on-call is to stay calm. All you need to do is have a clear mind, and write everything down on a paper. All you need is a pen and paper. Whatever events happens overnight, you need to write them down. Events related to handing over to the morning team, events related to admission, or if a patient falls, something on the ward that you need to report to the morning team. If you write down everything and always assess what is important and what is more important to be done at that moment, is something is going to help you on the long run. As you can see, when you work, you will get interrupted here and there by pages and nurses asking for admission orders or medication reconciliation, or even sometimes by your own physical fatigue. So stay calm and trust me, the morning always comes. The page was mainly for one of the patients who is on the medical board, and the patient is having some delirium. Presentation, whether on your medicine, whether you're oncology, patients, especially elderly people, get delirious over. And there are tons of causes of delirium. So this patient has a prostate cancer, has been delirious, and this is new for him. So I'm just thinking about my differential, like it could be infection, could be hypercalcemia. So I need to order some blood work just to figure out what's going on. I might just go and see him as well. And if the patient has risk on himself or other people, you always have to consider like chemical sedation or physical sedation. But it's very important to assess patients with delirium overnight and to investigate the underlying cause of delirium before making any decisions, okay? So yeah, that was one of the pages for patients on the ward. Okay. Hopefully after this I can get some sleep. I'm still very hopeful. It's 12:50 a.m. So this is a new day. So I just saw another fourth and fifth admission for tonight. I just got paid for seeing two patients. So there are two patients I needed to see in emerge. One of them was a 40-year-old patient with a breast cancer, and the other was around 50-year-old patient with metastatic melanoma. Both patients had different presentations. So one of the patients was presenting with a reaction related to the chemotherapy infusion. Some of the chemotherapy medication can lead to allergic reaction, and this patient developed a severe allergic reaction. Her blood pressure dropped, she became feverish, her heart rate was very high, and the other patient was presenting with cough and bronchitis and possible pneumonia based on his chest x-ray. So I went and saw the patients, and they both need to come in. So it's a busy night. Relatively, I haven't slept yet. So it's now 2:54. I've been working since yesterday, 7 or 8 in the morning. I started the clinic, and after the clinic, now I'm on call. It's 3 o'clock. So doing those admissions is going to take me around a couple of hours. So it's going to be 5 o'clock, 5-ish, around that time. So I haven't slept, and I don't think I'll sleep. 7 a.m. I received another consult. So I've been working for 24 hours straight. The consult is for a patient with febrile neutropenia. It's a common presentation we see a lot in patients on chemotherapy. So I'm just going to go and see the last consult, and hopefully we'll be done. I just came from seeing the last patient, so now it's 7:19 a.m. So I've been working for the last 24 hours, and then I'm gonna still be here for the next 2 hours, so that's gonna be 26-hour call shift. So the last patient, as I said, she was a patient with febrile neutropenia. Actually, it doesn't qualify to be called febrile neutropenia. So we call a condition a febrile neutropenia when you have low white blood cell count. So this patient, she had a fever, but she was on chemotherapy. Sorry guys, my brain's not working. I've been working straight for the last 26 hours. So this patient had a fever, and she's also on chemotherapy. But what makes me worried about her going home is the elevated white blood cell count. So it's something I need to discuss with the staff in the morning, how to manage her, because she might go home with oral antibiotics, or she might stay here with intravenous antibiotics. So it's a very tricky situation. So yeah, that's how usually being on call is. We see patients, we deal with ward issues. Also, the ward was busy. I dealt with some issues like medications, medication reconciliation sometimes, or ordering medication or ordering blood for a patient who became anemic. Also, one of the patients unfortunately passed away, so I had to go and pronounce their death. So this is how is it to be on call on the medical oncology ward. Okay, so I will keep you updated. Hopefully, the morning staff will be here. I will give handover, and then hopefully. Alrighty, and I'm done. It's 9:05. This is the next day. I've been working for 26 hours straight. I'm done. I finished my call shift, so I'm just gonna go home and enjoy the rest of the day. We usually get post-call days, so like to go and sleep, rest, do whatever you want, and that's what I'm gonna do. So, heading home. Let's go.